My name is Markus Mahl. I'm the Chair of Pediatric Pulmonology, Immunology in the Cystic Fibrosis Center at Charité University Medical Center in Berlin. I thank you for joining the symposium on CFTR modulators, where I will examine the question when CFTR modulators should be initiated for individuals with normal lung function and nutrition. Here are my disclosures, including personal fees for consultation, non-personal fees for participation in clinical trials, as well as research grants related to the development of novel therapies for cystic fibrosis. I want to start with looking at these trajectories of lung function determined by FEV1 and weight percentiles from the CFF patient registry that clearly show that most of our pediatric patients now have normal FEV1. Obviously, raising the question when treatment with CFTR modulators that are now becoming available for pediatric age groups should be started in this context. However, I also want to highlight what I think is an important issue here, and that is, although it has been possible to improve FEV1 as well as weight in younger birth cohorts, this has not resulted in a slowing of the progression here shown by lung function decline over time, which I think is a clear sign that the situation under current CF care is not ideal. And this has also been supported by many studies using other outcome measures, for example, chest CT for imaging or multiple breath washout to determine the lung clearance index as an outcome measure of ventilation sensitive for obstruction of the small airways. And what you can see in these studies is that there is significant structural damage and remodeling in most patients, even in many patients, even in the absence of changes in the FEV1, and the same is true when you look at the lung clearance index. So in this study here, examining the effect of comparing isotonic versus hypertonic saline in patients with preserved FEV1, it was found that many of these, by and large, pediatric patients already had an abnormal LCI. So taken together, this clearly demonstrates that spirometry is not sensitive to detect early but clinically relevant and significant lung damage. And this is obviously supported by observational studies in infants with cystic fibrosis that were done with the introduction of newborn screening by the OSGF group in Australia, but also other groups around the world. And the key findings here are that CF lung disease starts very early in early infancy with structural abnormalities, with neutrophilic inflammation that turned out to be a sensitive and important risk factor of bronchiectasis at preschool age, as well as ventilation inhomogeneity, at least in a subgroup of these infants diagnosed by newborn screening. And this notion of early onset and progression of lung disease, but also extrapulmonary manifestations, has been nicely summarized in a review article summarizing the data from many observational studies from many groups around the world that clearly showed early onset both of pulmonary as well as extrapulmonary manifestations, and also progression of these disease manifestations in preschool years, which I think is a strong rationale for early initiation of CFTR modulators that provide the opportunity to target the underlying cause of the disease in these patients. I think another important argument are the natural history data from patients with residual function mutations in CFTR that I think also provide an important support of the concept of early treatment, because if we think about it, these patients have residual function from birth or even in utero. And from these studies, we know that inborn residual function above a threshold of about 10% is associated with long-term exocrine pancreatic sufficiency, and that then higher levels of residual function are associated with milder disease phenotypes. If we look at the development of CFTR modulators and the current improvements in functional restoration, the prediction clearly is that improving CFTR function will translate into greater clinical benefits. But I think these natural history data also support the notion that the earlier we are able to do this, the greater will be the benefit for the patients in terms of preventing onset as well as disease progression. This notion is also supported by emerging real-world data. Here, these longitudinal trends of FEV1 and BMI that came out of the Irish registry of patients with gating mutations that were treated with Ivacaftor, and looked at FEV1% predicted 3 years before and then 3 years after starting Ivacaftor in different age groups: children below 12 years, 12 to 18 years, and then adults. And whereas all age groups showed a response to therapy by BMI, it is clear that the response to therapy at the level of FEV1 was clearly age dependent, with the youngest age group that started out with the highest FEV1 showing the greatest benefits, with actual stop of disease progression in the adolescent group, whereas Ivacaftor was not able to stop lung function decline in adult patients with advanced lung disease and impaired lung function. Another important piece of evidence in the puzzle are obviously clinical trials of CFTR modulators in pediatric patients. And as an example, I want to show the randomized controlled trial of lumacaftor, ivacaftor in F508del homozygous school-age children 6 to 11 years that had a normal mean FEV1 at baseline. And as you can see here, initiation of lumacaftor, ivacaftor resulted in a drop in sweat chloride and in vivo biomarker of CFTR function by about 20 millimoles per liter. And this improvement in CFTR function was associated with a rapid and sustained improvement in the LCI in this study, again, despite relatively normal mean FEV1 in this group, which I think really underscores the benefit of early initiation of therapy. This notion is already supported by open label trials and is currently further under investigation in randomized controlled trials, both of Lumacaftor, Ivacaftor in preschool children, age 2 to 5 years, as well as triple combination therapy with Elexacaftor, Tezacaftor, and Ivacaftor in school-age children, 6 to 11 years. What I think are really important, initially surprising, but also really important and spectacular data is this observation from an open label study with Ivacaftor in very young children, 12 to 24 months, with gating mutations, where it was shown that early initiation of restoration of CFTR function can actually restore exocrine pancreatic function determined by fecal elastase as a biomarker in a majority of these infants. And I think this is really important data supporting that very early initiation of this therapy can have substantial clinical benefits, not only on lung disease, but also on extrapulmonary manifestations, including the pancreas. The next step would then obviously be to go to preventive therapy in very young infants. There are no studies of CFTR modulators that have been performed or are ongoing. However, we asked this question in Germany with preventive inhalation of hypertonic saline in the so-called Fibrosis study, where we included infants in the first 3 months of life, and where we were able to show that this early intervention also improves the lung clearance index over a period of 12 months, and that this improvement is also associated with an improvement in weight, really supporting clinical benefit of very early therapeutic intervention. And this concept of a large potential of preventive CFTR modulator therapy is also supported by studies in the CF ferret with a G551D mutation that were conducted in John Engelhardt's lab. And what these studies showed is that early start of Ivacaftor, in this case very early, actually in utero, prevented the onset of lung disease, including mucus plugging in the conducting airways, as well as submucosal glands, but also other problems like bacterial infection and inflammation in these animals. Whereas withdrawal of Ivacaftor after birth again resulted in a CF-like lung disease with severe airway mucus plugging, also suggesting that this therapy will have to be continued lifelong to avoid this scenario. Importantly, they have not only looked at the lungs, but also at the GI manifestations. And I think it's again very important data that they were able to show that in utero initiation of Ivacaftor treatment also prevented the occurrence of meconium ileus, as well as improved weight, and again prevented exocrine pancreatic insufficiency or preserved pancreatic function in these G551D ferrets that were treated early and maintained on Ivacaftor therapy, which I think is a very important proof of concept that early therapy, in this case very early therapy, probably most beneficial in preventing onset of disease, but then also delaying or ideally preventing disease progression. I briefly want to summarize my talk. CF lung disease and extrapulmonary manifestations are present from infancy and show lifelong progression, even in patients with normal lung function and weight, treated with current standard of care. CFTR modulator therapy that is becoming available for pediatric patients is really an unprecedented opportunity to treat the underlying cause of CF in patients with responsive genotypes. And the natural history data from patients with CFTR residual function mutations, but also the preclinical studies in the CF ferret and clinical trials in patients with CF support early initiation of CFTR modulator therapy to delay or even prevent organ damage in the lung and extrapulmonary manifestations, and thereby achieve optimal long-term benefit. Obviously, the long-term safety and efficacy of early or even preventive intervention with CFTR modulators, ideally from early infancy, remains to be determined in clinical trials and in the real-world clinical setting. This I stop and like to thank you again for joining and listening, and I'd be happy to take questions at the live Q&A session as well as the online chats and conference platform. Thank you.
Hi, welcome to our symposium entitled Extrapulmonary Effects of Highly Effective CFTR Modulators. I'm Michael Stalving. I'm a pediatric endocrinologist from the University of Alabama at Birmingham, and I'd like to introduce my co-presenter, Luke Hoffman from the University of Washington. For this presentation, we have no relationships that we need to disclose. Now, I'll begin by talking mostly about the impact of CFTR modulators on nutrition, growth, and endocrine function. As the audience knows that the impact of CFTR modulator is now moving beyond that of pulmonary issues and into the other arenas, we will try to hit on some of those topics during today's talk. I will focus primarily on the endocrine issues, and we must go ahead and apologize for shortchanging any other areas such as reproductive, immune health, neurocognitive health, or musculoskeletal issues. As the audience knows, again, CF is a multi-system disease. Everything from sinus infections and sinus disease to lung health to bone issues, fertility issues, and GI issues. We will not be focusing on the lung function or lung infections. For those that are interested in learning more about the topic, we would like to point out a recent review that was published entitled The Extrapulmonary Effects of Cystic Fibrosis Transmembrane Conductance Regulator Modulators in Cystic. As a pediatric endocrinologist, one of my major focuses is that of linear growth or height or stature. And we know now, as data comes in, that linear growth in CF matters much more than we appreciated in the past. Children, we've known for many years that children with higher weight for length by age 2 have better long-term outcomes. And that height and weight at age 3 is a predictor of lung function at age 6. But what many folks don't know is that lower height or stunting in boys and girls before the age of 8 have a decreased survival, suggesting or giving us an independent predictor of mortality. Findings from the bonus study that we performed multiple years ago suggested an impact on very early growth in infants. In 231 CF newborn infants that were picked up by newborn screen between 2011 and 2015, we found that there was a significant drop-off in both weight and length by ages 1 to 3 months. What's interesting is that by age 8 to 9 months, with good aggressive nutrition and enzyme replacement, that weight catches back up. However, length does not catch up during the entire part of the study. When we look at other factors that may be contributing, such as insulin-like growth factor, we found that it was reduced. Now, insulin-like growth factor is the downstream product of growth hormone and is a reflection of not only the growth hormone status, but also can be a reflection of nutritional status. Insulin-like growth factor was further reduced in those that were persistently low length and low weight babies. However, we found that early stunting or poor growth was not explained by nutrition or respiratory factors, but more suggestive of pancreatic sufficiency. Why do we talk about this in a talk about CFTR modulation? Well, that's because the CFTR modulators have been actually shown to improve linear growth. Here's evidence from a study from both GOAL and ENVISION on the left-hand side, in which children with G551D mutation were treated with Ivacaftor. And you can see the top left graph, an improvement of height Z-scores in those treated with Ivacaftor versus those that were treated with placebo. Below that graph, you see a change in height velocity or growth velocity of those treated with Ivacaftor versus those treated with placebo. Why would this, what is the mechanism for this? And that's what's not 100% clear. And that's what we want to learn going forward in future studies. But one mechanism we decided to look at was through the use of growth factors. Next. You can see that over the first 1 month and 6 months that there's a significant change in IGF-1 concentration over that time period for those kids between 6 and 11 years. What's interesting is we went back and looked at past data on treatment of growth issues in CF. Next. Here you can see the change in IGF-1 over the 6-month period of those kids with G551D treated with Ivacaftor. We actually compared that to kids who were treated with growth hormone therapy many years ago as part of a stature-related trial. Next. What you can see is the change in IGF-1 of the kids treated with Ivacaftor was relatively similar to those that were treated with growth hormone. Next. Now, you can't talk about growth and not talk about bone health and body composition. CF-related bone disease is second behind CF diabetes in associated complications. Not only that, it increases in prevalence as the age increases. It has an impact on quality of life, potential transplant, and other general health issues. In addition, there's animal data that implies that there's an impact in very early bone accrual. Now, why would we think about modulator therapy in a bone health related issue? Next. One issue or one reason that we think about modulators is that we've actually shown through animal data that CFTR is expressed osteoblast proliferation and differentiation, as well as communication with the osteoclasts, which are involved with bone resorption. Finally, last but not least, obviously, is CF-related diabetes. It's the most common comorbidity seen in CF, occurring in 19% of all ages and 31% of those over the age of 18. It impacts quality of life, morbidity, and mortality, and it has a much higher incidence in those with pancreatic insufficiency and those with severe genotypes. It's best described as a progressive loss of insulin function and dysregulation. What would be the impact of modulator therapy in these individuals? And that's one thing that we're hoping that we have the future of studying in both studies such as Promise that is ongoing and Begin, which we're launching, to get a better understanding of the impact of diabetes, glucose metabolism, insulin regulation and control. And to give you an illustration of just one potential outcome, I'd like to show data from this registry of both the US and the UK. And here in the registry, you can see they compared outcomes of multiple different focuses and multiple distance. And what was found was that they demonstrated a reduction in both diabetes and bone disease in both those individuals treated with Ivacaftor versus those who weren't. And so this is, as I mentioned, is just one, for lack of a better pun, promise of what's going to happen in the future. And so I'll at this time, I will turn it over to my co-presenter, Luke Hoffman, to take us from here on the effects of GI tract, liver, and exocrine pancreas.
Thank you very much, Michael. Thanks for kicking things off, and thanks to the organizers for inviting us. Again, my name is Luke Hoffman. I'm a pediatric pulmonologist and a microbiologist, and so it may not be obvious why I would have been tasked with talking about the GI tract, as well as its affiliated organs, the liver and the pancreas, or the exocrine pancreas. Now, one of the best reasons to talk about the GI tract and CF is that GI symptoms are reported very often. They're often the earliest and sometimes most severe manifestations of CF, particularly in the patients who Dr. Stalvey and I see, which are children. And among those manifestations of CF in the GI tract include pancreatic exocrine insufficiency. So in addition to the endocrine insufficiency we just heard about, this is the inability to secrete pancreatic digestive enzymes into the intestinal lumen, which results in nutrient maldigestion and malabsorption, which can then lead to intestinal obstruction, as well as dysmotility, altered pH, and inflammation, which are distantly related to the pancreatic function. And CF also causes obstructive liver disease and progressive structural damage, which I'll talk about in a minute, most commonly late in childhood or early adulthood. And abdominal pain is among the most severe and common symptoms that's often reported by people with CF, which we understand very little. And you may wonder then, how do CFTR modulators impact all of these symptoms and manifestations? Well, there have been a couple of studies regarding GI function, and I'm going to start by talking about some evidence that Ivacaftor, of course, many of our observations come from our experience with Ivacaftor, decreased symptoms of GE reflux, gastroesophageal reflux, like burning, etc., which has been reported in a couple of studies. But the study by Gelfond et al. That I'm talking about showed normalization of small intestinal pH through a smart pill. And these two effects are likely related to each other. Now, since these effects are predicted to change the intestinal lumen environment, it's predicted that these effects might affect the microbiome, which is my interest when it comes to the GI tract. And here are some results from a recent study from my laboratory. This reproduces some findings that have been seen before. On the far left, where we showed in 25 healthy infants without CF, there is a stereotypical development of the fecal microbiome in these infants. And this is age in months on the x-axis, 2, 4, 6, 9, and 12 months. And each of these bars represents the average fecal microbiota. So each one of these colors represents a group of bacteria. These are at the phylum level. But most importantly, what this is supposed to show is that there are some stereotypical dynamics here, a decrease in these inflammation-associated bacteria, the proteobacteria in orange, and an expansion of these anti-inflammatory microbes in blue, the firmicutes, and stability of these anti-inflammatory microbes in the red. And what you can see when we looked at the fecal microbiota with many more time points in infants with CF is that those dynamics are not just muted, but actually delayed and absent in some cases, including persistence of these pro-inflammatory proteobacteria and decrease over time in these anti-inflammatory bacteroidetes, for example. But most importantly for this talk, what we found is that each of these features of this dysbiosis is most magnified in the infants who failed to grow. And we found that this association may be related to an inability or incomplete secretion of IGF-1. So that all of this links together the fecal microbiome or the GI microbiome and perhaps endocrine function and growth. But we also found that body length is not the only association with this fecal dysbiosis. It's also associated with fecal measures of inflammation, linking together with intestinal inflammation and nutrient malabsorption, particularly fat. So how do CFTR modulators impact this dysbiosis, which we think is important for multiple features of intestinal dysfunction? Well, there have been very few studies. However, there have been a couple of case reports, some early data, and a really nice study from Chi Oi's laboratory in Australia, which showed, for example, that a fecal measure of inflammation tended to decrease in people who started on Ivacaftor, and several features of the taxonomic dysbiosis improved as well. So all of this provides some encouraging data suggesting that modulators will in fact improve these findings. When it comes to the exocrine pancreas, as we alluded to before, most people with CF are born with pancreatic exocrine dysfunction and pancreatic damage. And this pancreatic insufficiency, again, is a key contributor to growth failure, nutritional deficiencies, and intestinal obstruction. However, since people are born with this problem, it's not immediately clear whether restoring CFTR function after birth might improve pancreatic exocrine function. And one of the ways we follow this is with a marker, fecal elastase or fecal pancreatic elastase, a protease produced by the pancreas. So there are some encouraging data, again, from our experience with Ivacaftor, the 24-week Kiwi study, and the follow-on 84-week Climb study of children ages 2 to 5 with gating mutations who started on Ivacaftor. And what you can see here is that fecal elastase did tend to increase significantly through even at 24 weeks, but continued to increase over the 84 weeks of the Climb study. And there are some case reports that support this finding, but of course, they need to be verified in larger, longer studies with the new generation CFTR modulators. When it comes to CF liver disease, CFTR dysfunction leads to a range of different problems throughout the hepatic system, including the gallbladder, bile ducts, and the liver tissue itself, which ultimately can lead to cirrhosis and portal hypertension at end stage. And we don't really understand the pathogenesis of any of these features very well. There have been a number of really nice studies, but only a few studies have really examined how CFTR modulators might affect liver function and damage. But these studies are complicated by the fact that CFTR modulators also have liver toxicity on the list of their potential side effects. So trying to study the beneficial or salutary effects of CFTR modulators in the liver concerning when you're studying drugs that also have liver toxicity turns out to be very complicated. And again, one of the best sources, I think, and most meaningful sources of data right now came from this very large registry-based study in the United States and UK, Besanova study that we heard about a little bit ago, that compared outcomes, reported outcomes in the registries in people who were matched with CF, people who were on Ivacaftor in blue and those who were not in gray, and just focusing on the hepatobiliary complaints that were reported. In both the US and the UK, significantly fewer people reported hepatobiliary problems when treated with Ivacaftor. So again, this is early, but it provides some encouragement. And there are some case reports that have discussed improved histopathology in liver biopsies from the OI lab again, for example. So in summary, evidence is accruing regarding the effects of CFTR modulators on many organs beyond the lung. Improvements have been observed in all of the organ systems that we talked about today, including pancreatic, endocrine, and nutritional and bone outcomes, as well as the GI tract and microbiology and measures of absorption and inflammation. Many of these findings are quite early, and they need to be validated in larger, longer studies of new generation modulators. But I wanted to point out, if we haven't heard about this before today, that observing these effects as people restore CFTR function, offers one of the best opportunities historically to really understand how CF and CFTR dysfunction lead to these problems and the pathophysiology. And there are a couple of studies that I wanted to finish by mentioning that aim to do exactly this. They are, for example, and there are other studies as well. I'm just mentioning the two that Dr. Stalvey and I are fortunate enough to be involved in. The PROMISE study of people older than 6 starting on highly effective modulators, and the BEGIN study, a parallel study in young children with CF who are starting on highly effective modulators. And both studies are collecting very diverse outcome measures and observations, which we hope will yield a lot of data that will lead to a very different talk within a couple of years. So with that, I'd like to thank the organizers and to my co-host, Dr. Stalvey, and we thank you for your attendance.
Good morning. I'm grateful for the organisers of this symposium at the North American CF Conference being held virtually this year. I have the privilege of being able to update you on the impact of CFTR modulators in patients with advanced CF lung disease. I'm Scott Bell and I'm based in Brisbane. These are my disclosures and current grant support. On the right side of this panel, you'll see the Cystic Fibrosis Foundation drug development pipeline. In the purple bars are the drug pipeline for CFTR modulators. Today I'm going to focus on the left-hand 4 columns. Currently available CFTR modulators for patients with up to 90% of the mutations seen in patients with cystic fibrosis. It's important to note that in the randomized controlled trials, to demonstrate effectiveness and safety for CFTR modulators in patients with cystic fibrosis, those patients with the most severe lung disease in our clinics have been systematically excluded from these studies, including those patients with FEV1s of less than 40% predicted, those patients who have very frequent exacerbations and poor clinical stability, and also patients with a number of different microbes in their airway. In recent years, real-world analysis has become an opportunity to complement and expand on the finding of randomized controlled trials. We're all well aware that randomized controlled trials set the standard for eliminating bias and determining the efficacy and safety of new therapeutics. However, a significant limitation is their generalizability in the broad population living in a diverse number of clinical practice settings. Real-world analysis are able to be performed in actual practice settings and may give us a better assessment of actual effectiveness and safety. They have significant limitations, however, including the lack of randomization and the potential for selection bias, the quality of the data entry, and the potential for not accounting for unmeasured confounders. In recent years, improving study designs, advances in methodology, and the utilization of more comprehensive data elements through registries have provided an opportunity for the expansion of real-world studies in our patients. To date, there have been several types of studies to assess the impact of modulators in patients with severe CF lung disease. Importantly, in the randomized controlled trials, there are patients who at screening fulfilled the inclusion criteria of an FEV1 of greater than 40% predicted. Yet on the first day of therapeutics, their FEV1 had fallen below 40%. There are a number of different approaches to real-world analysis, cohort studies comparing patients with a specific CFTR mutation and a specific CF modulator are compared with a control group with a different severe mutation where they have not been exposed to CFTR modulators. Analysis of before and after exposure to modulators, uncontrolled and open studies, often associated with early access programs, and most recently, utilising CF registries to undertake real-world analysis. Key endpoints include change of lung function and nutritional status, quality of life, rates of pulmonary exacerbation, changes in airway microbiology, exercise capacity, and even recently, changes in survival and rates of transplantation. These are some examples where analysis has been undertaken in those patients who, at inclusion into the randomized control trial, had an FEV1 above 40% predicted. Yet on day one of the study, this had fallen to less than 40% predicted. You can see that these analyses have been performed here in the traffic and transport Lumacaftor Ivacaftor study, the Tezacaftor Ivacaftor studies, and most recently the triple therapy studies. The populations where this was an impact was about 1 in 11 of the patients participating in the studies. In these two columns, you see the difference between the change in FEV1 in the population as a whole and those patients with the most severe disease with FEV1s on day one of less than 40% predicted. And overall, the rates are very similar to what's seen in the general population of the study. Similarly, in the Lumacaftor Ivacaftor study, rates of reduction in pulmonary exacerbations are similar in those patients with severe disease, FEV1 less than 40% predicted on day one, compared to the population as a whole. Here are a number of cohort studies, usually open design, and in many cases a part of early access programs. Most are single site, but not all, and they involve relatively small patients with severe lung disease, with receiving either Ivacaftor for gating mutations or Lumacaftor Ivacaftor in patients homozygous for the F508 variant. Overall, the improvement in lung function is perhaps more modest than one had seen in the randomized controlled trials. However, where reported, rates of reduction in pulmonary exacerbations are similar to those seen in the randomized controlled trials. One of the benefits of real-world analysis is the potential for understanding rates of adverse events, particularly in those patients with the most severe disease. In the airborne analysis of the traffic and transport study, there were 81 out of 1,072 patients with severe lung disease at the commencement of the study. Rates of adverse events with dyspnea and abnormal respiration were 2 to 3 times higher in those patients with severe lung disease receiving active drug compared to those receiving placebo. In the randomized controlled trial, however, only a relatively modest proportion and number of patients actually withdrew from the study. Importantly, in the cohort studies, rates in those patients with severe disease with adverse respiratory events were significantly higher, and approximately 1 in 4 patients actually had to withdraw from therapy. This certainly was higher than seen in the randomized controlled trial. Recently, registry studies have examined the impact of long-term treatment with Ivacaftor in patients with gating mutations. This is an analysis of the US and the UK registries, and where you can see overall reduction in hospitalization and pulmonary exacerbations is similar in both registries. We focus on the most severe patients. There's generally a reduction in hospitalization similar to those patients with moderate disease, as seen here, and similarly in the UK registry, but perhaps slightly less than those with the mildest lung disease. In this analysis, we also see here that in patients receiving Ivacaftor, there's a reduced rate of mortality in both the US and UK registries, and a reduction in rates of organ transplantation. We are well aware that CFTR modulators are not uniformly available or funded across the globe. And whilst these figures are slightly out of date now, they do highlight the issue of availability of modulators in South America, South Africa, the Middle East, and also Eastern Europe, for both here on the left, Ivacaftor, and here on the right, Tezacaftor, Ivacaftor. In an interesting analysis just published in the Journal of Cystic Fibrosis by the Toronto group, a simulation has been performed utilising the Canadian Cystic Fibrosis Registry with the impact of no triple therapy, the A columns, and the introduction of triple therapy, the B columns, in 2021 on the overall population size in Canada, increasing from just over 4,000 to 5,500 over the next 11 years. But importantly, in the outer years, the differential with, these are simulation studies, the differential, no triple therapy versus triple therapy introduced in 2021, the impact on numbers of patients with mild disease and moderate disease, and in fact, as you can see here, reduction in the proportion of patients with severe disease. Interestingly, rates of lung transplantation may reduce in the outer years, but relatively modest and probably reflect those patients still requiring transplantation with the most severe form of lung disease. On the right-hand side, one sees survival analysis. Again, this is the probability of survival in 2030. The solid bar here indicates no triple therapy, and it's estimated that the Canadian population will have a median survival in 2030 of just less than 60 years. If Ivacaftor was introduced in 2021, this will increase, is predicted to increase, survival by 10 years. However, if triple therapy is not introduced until 2025, so a delay of 4 years, the improvement in survival will be halved. What's the impact of CFTR modulators predicted to be over time? Well, on the left-hand panel, we see patients receiving Ivacaftor in the US and the UK registry. And FEV1, certainly the rate of decline of FEV1 in patients receiving Ivacaftor is less than the comparator group here in the dark bars, both in the US and the UK registry. However, there is some decline in lung function over time. Rates of pulmonary exacerbation or hospitalisation, as represented here, in patients in the grey bars receiving Ivacaftor compared to those patients in a comparator group. Certainly there is, over the last 5 years, a reduction in rates of hospitalisation, but they are still significant. And so these patients receiving Ivacaftor, approximately 1 in 4, will require hospitalisation each year. So one question we have to ask ourselves, particularly in those patients with the most severe form of CF lung disease, is will CFTR modulators and their impact endure long term, and to what extent? Importantly, we will see a reduction of pulmonary exacerbations, and we will have healthier patients in the clinic, which will mean that we need to pivot our care to a more outpatient-based care. And that's certainly been exaggerated in 2020 with the requirement to pivot further to virtual care in the setting of the COVID-19 pandemic. Particularly in adult care, it may give us an opportunity to actually change from a more reactive type of delivery of care to a more proactive care. We do also need to consider what aspects of the complex treatments that our patients receive can be dropped. In fact, many of them already will have been dropped by our patients. Longevity is associated with new complications, and we already know that metabolic syndrome and nutritional excess is increasingly common in our older adults with cystic fibrosis. And in the setting of CFTR modulators, weight gain is almost universal. Obesity and metabolic syndrome and other complications that appear to be related to longevity, such as colorectal cancer, are going to be really key parts of management of the patients with cystic fibrosis into the future. We may well need to teach our transplant colleagues a little more about the changing nature of our patients, particularly those with most severe lung disease. This is an important guideline published in the Journal of Cystic Fibrosis in 2019. The guidelines recommend routine discussions about disease trajectory and that lung transplantation should be a potential throughout life. This should be upgraded to an annual discussion for transplantation with a focus particularly on addressing areas of potential barriers to transplant. These are two of the recommendations that I'm going to focus on here, and that is that the CF Care team should initiate discussions regarding transplantation in all patients with cystic fibrosis with FEV1s of less than 50% predicted, and that the Foundation recommends CF clinicians develop relationships with their peers at their partner transplant centres. Perhaps this is even more crucial in the setting of the changing survival and the impact of modulators on our patients with severe lung disease. We know that survival is improving for people with cystic fibrosis. It's also improving dramatically for those with the most severe form of lung disease. In the seminal work performed by Eaton Kerem in the 1990s, median survival for those patients with FEV1s of less than 30% predicted was a mere 13 months. More recent analysis, initially in the UK registry by George and then by Kathy Ramos, published in Chest 3 years ago, has demonstrated that those patients with the most severe lung disease are surviving much longer than previously, median survival of up to 6.6 years in those patients with the most severe lung disease. It is important to note that some patients are dying soon after reaching this threshold, and others are living many years, thus challenging how do we go about counselling our patients on the timing of transplantation assessment. So to conclude, I'd like to highlight that the response to CFTR modulators appears to be as robust in patients with cystic fibrosis with severe lung disease as it is for the CF population as a whole. We do need to consider, particularly in those patients with the most severe form of CF lung disease, whether the impact will endure. What do we say to our patients about transplantation when they're listed with severe lung disease and yet they've just demonstrated the best lung function that they've had for 5 to 10 years and no exacerbations? Models of care will need to change. And that has the potential to impact on the skill base to deliver care for those with advanced lung disease. Finally, we need to be in close contact and undertake ongoing education of our lung transplant services to ensure that they understand the impact of modulators on patients with advanced lung disease. Finally, I'd like to acknowledge the multidisciplinary team I've been lucky enough to work with, particularly the clinical trials team and our local lung transplant program, and of course our patients. Thank you very much.
Hi, I'm Kathy Ramos. I am an adult pulmonologist at the University of Washington, and I work in cystic fibrosis and lung transplant. I have grant support from the CF Foundation, the NIH, and Chest Foundation in partnership with Vertex Pharmaceuticals. Today, we will talk about the pros and cons of using CFTR modulator therapy after solid organ transplant and pro and con rebuttals. So CFTR modulator used after non-lung solid organ transplantation is probably the least controversial of the arguments for the use of CFTR modulators after solid organ transplantation. There's growing experience across North American CF centers with this, and there are several reports of liver transplant recipients or liver kidney recipients receiving Tezacaftor for treatment of lung disease and have significant pulmonary benefits. FDA approval was based on lung function benefit, and that is directly relevant to individuals with native CF lung disease. There have been some individuals post-liver transplant who have been removed from the lung transplant waiting list due to the substantial improvement in their lung function on Elexacaftor, Tezacaftor, Ivacaftor. There are special considerations in this population, including liver toxicity that may require increased monitoring for elevation in transaminases, and it requires consultation with the transplant hepatology team. There have been experiences with the transplant hepatology teams requesting a delayed start to triple therapy for individuals who are experiencing complications in their liver graft. So the overwhelming experience seems to be that hepatologists are open to the use of triple therapy post-liver transplant. Drug-drug interactions may necessitate changes to the immunosuppression regimen or dose to maintain therapeutic levels. And CFTR modulator dose has actually been reduced due to liver toxicity in some of the liver transplant recipients, but that has not been studied for efficacy in randomized clinical trials. The recommendation here is to initiate CFTR modulator therapy after non-lung solid organ transplantation in coordination with the transplant team. When considering CFTR modulators after lung transplant, it's more complex. As we've heard today, CFTR modulators and triple therapy specifically have implications for endocrine, GI, and other non-pulmonary manifestations of CF. I'll share some data related to the effects of CFTR modulators on sinus disease and highlight an NACFC poster with more details available. Post-lung transplant survival is better among individuals with less severe CFTR mutations, and I'll present some unpublished data related to an association of genotype with post-lung transplant survival that's being presented in an NACFC poster. Finally, I will describe the post-lung transplant experience with triple therapy in the CF Lung Transplant Consortium. Chronic lung allograft dysfunction, or CLAD, is sometimes referred to as chronic rejection, and it is the most frequent cause of death for individuals who have lived at least 1 year post-lung transplant. This figure shows that by 5.5 years post-lung transplant, more than half of adult lung transplant recipients with CF have obstructive CLAD. Surgical treatment of sinus disease has been associated with a decreased risk of pulmonary infections, and for patients in whom sinus pathogens were eradicated, there was an improvement in 5-year survival and reduced rates of CLAD. And so here I'm presenting some data related to CF, sinus disease, and triple therapy. In a single center pre-post study designed with 43 patients with CF who had not undergone lung transplant, Dr. Domingo and colleagues evaluated the effect of triple therapy on the sinonasal outcome test, or SNOT-22. It was recently published in JCF, and there was a statistically significant and clinically meaningful decrease in the SNOT-22 from 34 to 24 over 3 months. In a separate study at 2 sites with 33 patients, presented in a 2020 NACFC abstract by Dr. Stapleton, and colleagues, there was also a statistically significant and clinically meaningful improvement in sinus symptoms rated by the SNOT-22 after triple therapy initiation, and the benefit was sustained for at least 6 months. This study also evaluated endoscopic sinus exams and olfaction, with data collection ongoing for those endpoints. This study by Dr. Clausen and colleagues is presented in an NACFC poster this year, and it used a merged data set containing records from the CF Foundation and UNOS OPTN registries for transplants between 2005 and 2017 for CF in the US. CFTR genotype is associated with phenotype and disease severity, as we know. In this study, genotypes were classified as high risk if there were 2 mutations from functional classes 1 to 3, low risk if there was at least 1 mutation from class 4 or 5, and as unclassified for all other mutations. Patients with unknown genotype were excluded from these analyses. This figure shows the Kaplan-Meier estimate for survival without retransplant. As you can see, the CFTR genotype is associated with post-transplant survival, with the low-risk genotype shown in blue having higher survival probability over time, suggesting a potential role for CFTR modulator therapy for management of extrapulmonary manifestations of CF after lung transplant. We're performing an electronic health record-based cohort study with patients eligible between October 2019 and September 2020 at 15 sites within the CF Lung Transplant Consortium, and we're identifying CF lung transplant recipients who've been prescribed triple therapy after lung transplant. There's a report of approximately 100 patients across the 15 sites who've been prescribed triple therapy after transplant. Only about 4 of the sites report 0 patients on triple therapy after transplant, and there's a wide variability in practice related to the prescription. Identifying the indications for prescribing Trikafta was a primary objective of this study, and we found that the most commonly reported condition that factored into prescribing Trikafta was sinus disease, followed by GI symptoms, then diabetes and low BMI. Interestingly, for some patients, CLAD and considering retransplant were also relevant factors, but most often these were in combination with sinus disease or low BMI. There is an association of triple therapy with increased BMI, and this is true again in patients who are post-transplant, but importantly, it is more relevant for people with an initial BMI less than 18.5 or low BMI as a factor for prescribing triple therapy after transplant, where their BMIs increased much more substantially than the overall cohort. Unfortunately, we don't have objective measures for change in sinus symptoms or GI symptoms in the current lung transplant consortium cohort, but these data will be helpful in an observational way. I'll mention it here and I'll come back to it again. I think we need a randomized controlled trial to evaluate the potential benefits and harms of CFTR modulator therapy post-transplant.
Kathy, thank you for doing that nice presentation of the reasons why we should consider Trikafta. I'm going to take the contrary review. But by introduction, my name is Joe Paluski. I'm at the CEF and Transplant Centers at the University of Pittsburgh. And I have disclosures to reveal for grant support from a number of clinical trials, none of which are really relevant to this presentation. What I'd like to focus on is the impact of chronic rhinosinusitis and the potential rationale for why we would try triple therapy after lung transplant, and then discuss why I have significant reservations. So first of all, the impact of rhinosinusitis. I think we've appreciated over the last several decades from a number of different investigative groups that the sinus disease may contribute to lower airway problems after transplant. In particular, upper airway cultures are strongly correlated with BAL cultures, particularly for Pseudomonas, MRSA, and Burkholderia. And even more compelling is data that there are similar gene expression profiles in Pseudomonas strains between the upper and lower airways. Additional, somewhat anecdotal evidence is that endoscopic sinus surgery in a couple of centers resulted in fewer bacterial isolates in the lung allograft, reduced clinical pulmonary infections, and less antibiotic utilization in single center observational studies. If we think in terms of what happens to allografts that have colonization after transplant compared to those that don't, the group in Belgium published a paper back in 2008 that suggested a relationship there. And the data is shown here. where they divided the cohort of approximately 90 patients into those who had no Pseudomonas or other CF pathogens isolated from their lower airways in the solid line, and looked at the impact or frequency of lung allograft dysfunction, and compared that to a group where the lower airway cultures were positive. And as you see, there's a significant difference between the freedom from chronic rejection. When they looked at survival at 1 year, after 1 year, the individuals who had lower incidences or no lower airway pathogens had a slightly better survival. Again, intriguing evidence that would suggest that if we can protect the airways from the sinuses, patients may have better outcomes. And for me, this serves as a rational consideration where one could hypothesize that the CF sinuses serve as a bacterial reservoir for lower airway colonization and infection, that colonization infection leads to an immune response and promotes the development of chronic lung allograft dysfunction. We think about how modulators could influence this. A modulator, such as the two highly effective modulators, could alter the sinus microbiome, normalize it in a way, and that effect could be that we reduce the lower airway colonization and block an immune response that would lead to allograft dysfunction. And while a compelling hypothesis, we unfortunately don't have good data to suggest that this occurs, but I will grant Dr. Ramos that this is an important consideration. A second major consideration is drug interactions. We're all familiar with the interaction between azole antifungals and the highly effective modulators or prolongation of the half-life. Importantly for many to remember is that the calcineurin inhibitors are metabolized by the same pathway, and that there's an important potential increase in tacrolimus or cyclosporin levels when one adds triple therapy or monotherapy with ivacaftor. Similarly, for the mTOR inhibitors, the CFTR modulators may increase the levels of these drugs. So if one chooses to try a modulator in patients on these calcineurin inhibitors or mTOR inhibitors, drug levels must be monitored very carefully with a consultation, ideally with a pharmacologist. The third issue for me is cost, and I think we all have responsibility as physicians to consider cost benefit as we prescribe therapies. The Institute for Clinical and Economic Review published in April of 2020 their analysis on the effectiveness of the triple therapy CFTR modulator and concluded that these agents provide a substantial net health benefit over standard of care. Those of us who practice in CF know that this is the case based on the compelling improvements in lung function, quality of life, and a reduction in pulmonary exacerbations. However, none of these endpoints are relevant to the post-transplant population as best we can tell. When you look at cost, the cost per life year gained in their analysis based on the current cost of these agents is approximately $1 million per year. So significant cost. So this leads me to conclude that if one thinks of the best case scenario for CFTR modulator use after transplant, we may see improvements in symptoms in the sinus disease in particular, but at high cost. We may see an increase in survival by reduction in sinus disease and potentially improved nutrition, but this is really at the level of hypothesis with no data to do it. And so ideally, this should be studied very carefully before it becomes standard practice. I'll comment briefly on nutrition. This has been a source of debate in the transplant community for a long time. And what we know from early registry data from the UNOS registry in 1995 to 2003 lung recipients is if you looked at individuals with malnutrition or obesity, they had worse transplant survival with CF, and those data are shown here. The normal weight group is shown in the solid line. The underweight group under BMI of 18.5 is shown in the gray line, and the overweight, which is a very small population of 34 patients, had the worst outcome of all. We know that Trikafta or the CFTR modulators improve nutrition, and we're optimistic that the number of patients who come to transplant with extremes of nutrition should improve over time, particularly on the underweight side. More recent data from Kathy Ramos in a UNOS registry from 2015 to 2000, going back to 2005, showed that survival was slightly better for patients who had a better BMI, but these differences were quite small, and both groups had better survival than individuals who had IPF or COPD as a comparison. So nutrition is important, and one could use that as a rationale for wanting to use Trikafta, but again, we have to be cautious given the risk and the cost. We think about tolerability. Kathy mentioned the study in the post-transplant consortium, and of 40 patients who started, almost 40% discontinued, and of those, only 5 restarted. The reasons for stopping are listed here and vary from pulmonary symptoms to lack of subjective benefit to abdominal discomfort. In our own personal experience, I'll confess that I prescribed Trikafta in 5 patients after transplant, and we've seen intolerable GI or GI side effects or rash in approximately 3 of them. We have 1 patient who's clearly benefited with weight gain and a reduction in lower airway infection. So the jury is very much still out. So to summarize my thoughts, I think that triple therapy or Ivacaftor should not be used in all eligible lung transplant recipients for CF, but there are potential indications for refractory sinus disease, despite maximal medical and surgical therapy, or for refractory malnutrition, where the key word for me here is refractory.
Thank you, Joe. I agree with Dr. Puluzki about several things. There are less expensive ways to manage CF-related chronic rhinosinusitis, and the effect on CLAD is likely through sinus management. Malnourished recipients may have the biggest potential benefit for with triple therapy, and there is risk inherent to drug-drug interactions. I disagree that the benefits of Trikafta may be limited to those with chronic rhinosinusitis or malnutrition. We do not fully grasp the many systemic implications of highly effective CFTR modulators and the potential role of inflammation in CLAD, the potential impact on malignancy post-transplant, and other important effects yet to be identified.
Thank you, Dr. Ramos. So we are gradually coming to some consensus here. I agree that modulator use in liver and other non-lung solid organ transplant recipients makes perfect sense, working in close collaboration with the transplant center. I also agree that the extrapulmonary manifestations of CF could contribute to lung transplant complications. And I'll go one step further in that individuals with CLAD may actually have CFTR airway dysfunction despite being genetically normal, as we've seen in tobacco smokers, and that CFTR modulators could mitigate that. But again, this is very much a theoretical risk, unfortunately without data to support it. I disagree to some degree that the extrapulmonary effects of CFTR dysfunction on the immune system are important. I think the data suggesting that CFTR impacts host defense and T-cell mediated immunity is a bit of a stretch. And the fact that we have the best post-transplant survival in individuals with CF, and we have similar incidences of rejection and opportunistic infections, for me would suggest that any effect on the immune system is likely to be trivial or at all. And I really think that the sinus nutrition is the major potential benefit of highly effective modulator therapy. So having said that, I think that we can summarize this session by saying that in non-lung solid organ transplant recipients with CF, a triple therapy or Ivacaftor should be used in conjunction with the transplant team. We agree and propose that for CF lung transplant recipients, the extrapulmonary manifestations likely are important and may contribute to the development of chronic lung allograft dysfunction and contribute to decrement in survival. The rationale and these observations and speculations suggest that highly effective CFTR modulators really should be studied in a randomized controlled trial to determine the benefits and harms in the lung transplant population. For now, we have Kathy's registry study with hope that that will provide at least some insight in the lack of a randomized controlled trial. So we thank you all for joining the session and look forward to our group discussion later today.
you.